If you listen to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome, I'm Fernando, HCP in the UK. Today we're going to cover what to do when we encounter abnormal liver function tests with a cholestatic pattern, always focusing on what is relevant in primary care only. This episode is based on the British Society of Gastroenterology guidelines on abnormal liver function tests. A link to it is in the episode description. Right, let's jump into it. And let's start by remembering that there are three common patterns of abnormal liver function tests. A cholestatic pattern, normally showing a high alkaline phosphatase and gamma-GT, which is what we will concentrate on today. An isolated raised bilirubin with otherwise normal liver function tests, and a hepatitic pattern with a raised ALT and AST indicating hepatocellular injury. By the way, if you're interested in finding out more about the last two types, make sure to watch the corresponding episodes on this channel. The links are in the episode description. As we have said, liver function tests showing a cholestatic pattern normally present with a high alkaline phosphatase and gamma-GT. Alkaline phosphatase, or ALP, is produced mainly in the liver, but is also found in bones, intestines, kidneys and the placenta. Levels are physiologically higher in childhood because of rapid bone growth, and in pregnancy due to placental production. A raised alkaline phosphatase can come from either hepatic or non-hepatic sources. The main source of non-hepatic ALP is bone. ALP increases in bone disease because it is produced by osteoblasts, the cell responsible for forming new bone. Any condition that increases osteoblast activity or bone turnover, such as healing fractures, Paget's disease, bone metastasis, or vitamin D deficiency, causes osteoblasts to increase their activity, releasing more ALP into the circulation. We should remember that the most common cause of an asymptomatic non-hepatic raised ALP is vitamin D deficiency. Vitamin D deficiency increases bone turnover because low vitamin D reduces calcium absorption from the gut. To maintain normal calcium levels, parathyroid hormone rises and stimulates bone breakdown to release calcium. This increase in bone remodeling activates osteoblasts, leading to a rise in ALP. But as we're focusing on liver function tests, what is the source of a raised hepatic ALP? From a pathophysiological perspective, hepatic ALP rises when bile flow is impaired, also known as cholestasis. And why does cholestasis cause a rise in ALP? It happens because alkaline phosphatase is found in high concentrations in the cells lining the bile ducts. When bile flow is impaired, pressure builds up in the biliary system and the bile duct epithelium becomes irritated. This stimulates these cells to produce and release more ALP into the bloodstream. This is the reason why ALP rises, for example, in gallstone disease, strictures or cholangitis. On the other hand, gamma-GT is found in the liver but not in bone. Therefore, when ALP is raised, measuring gamma-GT helps determine whether the source is hepatic or non-hepatic. A raised ALP with a normal gamma-GT suggests a bone-related cause, whereas a raised ALP with a raised gamma-GT supports a hepatic origin and should prompt further assessment of cholestatic liver disease. Gamma-GT rises in cholestasis because it is also highly concentrated in the cells lining the bile ducts. When pressure builds up in the biliary system, these cells release more gamma-GT into the bloodstream. In addition, cholestasis causes oxidative stress because retained bile acids are toxic to liver cells. In response, the liver increases gamma-GT production as gamma-GT is involved in antioxidant and detoxification pathways, leading to the characteristic rise in cholestatic liver disease. A high gamma-GT can also be due to obesity, excess alcohol, or medications. In obesity and non-alcoholic fatty liver disease, fat accumulation within the liver creates oxidative stress, so the liver upregulates gamma-GT to protect hepatocytes from free radical damage. In this context, an elevated gamma GT reflects metabolic stress rather than structural cholestasis. In alcohol use, ethanol metabolism produces toxins that also generate oxidative stress, which also stimulates gamma GT production as part of the liver's detoxification response. We will not go into detail on how to proceed with an isolated raised ALP, that is, with a normal gamma GT, as today we're focusing on cases where there is clear hepatic involvement, meaning that both ALP and gamma GT are high in a true cholestatic pattern. How should we investigate and manage these patients? When we manage patients with any abnormal liver function tests, we must begin by recognizing red flags that require urgent action. According to the British Society of Gastroenterology guidelines, either signs of synthetic liver failure, such as unexplained clinical jaundice, a low albumin or a high INR, or if there is suspicion of malignancy, for example, unexplained weight loss or marked cholestasis, then the patient should be urgently referred or admitted for a specialist assessment. If the pattern is cholestatic, we will proceed with a full liver screen. This is because cholestatic abnormalities are often related to structural biliary disease, autoimmune cholestatic conditions, or infiltrative disorders, and these require a full diagnostic approach. What tests should be done in a full liver screen? A full liver screen should include an ultrasound scan of the liver and biliary tree, which is the first-line imaging test. Ultrasound helps identify biliary dilatation, gallstones, strictures, masses, or features of chronic liver disease. In addition to imaging, blood tests should include hepatitis B and C, an autoantibody screen, serum immunoglobulins, ferritin and transferrin saturation, and often, and where clinical appropriate, a celiac screen, alpha-1 antitrypsin levels, and ceruloplasmin. These tests collectively help detect autoimmune cholestatic diseases such as primary biliary cholangitis, metabolic conditions such as hemochromatosis or Wilson's disease, and chronic viral hepatitis. It is also worth emphasizing that this full liver screen is recommended not only for cholestatic abnormalities, but also for patients who present with a hepatitic pattern, as the British Society of Gastroenterology guideline advises a comprehensive assessment irrespective of the pattern or the degree of derangement once initial red flags have been excluded. The management in primary care is fairly simple because the British Society of Gastroenterology recommends that once initial investigations have been completed, these patients should be referred to secondary care for further assessment. This applies both when a cholestatic picture comes with abnormalities in the liver screen, and also if the alkaline phosphatase and gamma GT remain persistently high, even in the context of normal investigations. Referral is indicated because persistent cholestatic abnormalities indicate underlying pathology that usually cannot be adequately diagnosed or managed in primary care. So that is it, a review of abnormal liver function tests with a cholestatic pattern. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.